If you are a dental hygiene student struggling with pharmacology, this video is for you. Today we're going to be talking about cardiovascular medications. So first up, let's talk about cardiovascular contradictions, especially when it comes to treatment. First thing I'm going to talk about is blood pressure. It's the number one cardiovascular condition that we see, hypertension, the silent killer. So let's review normal versus high blood pressure. Normal blood pressure is 115/70 or 120/80, but that's kind of elevated. Moving more towards elevated would be 120 to 129/180. Stage 1 would be 130 to 139/90. Stage 2 would be 140/90 or greater. Then we have hypertensive crisis, that is 180/120 or greater. Anything over about stage 2, we would tell them, hey, I think you need to go check out your primary care provider. I can't treat you today. Other conditions, angina, that is a precursor to MI. Anything uncontrolled heart failure, uncontrolled arrhythmias. Really quickly, what is the cardiac dose for epinephrine? 0.04 milligrams. Good job. If it's for levo, what would it be? 0.2 milligrams. Good job. All right, now let's really quickly talk about the 4 antihypertensive medications. We have diuretics, ACE inhibitors, ARBs, angiotensin receptor blockers, and calcium channel blockers. And we also have beta blockers and alpha blockers. So diuretics, they're usually first-line therapy for hypertension. They increase the excretion of sodium in water, so it lowers the BP. It opposes aldosterone, which remember that normally rises BP. Some side effects, xerostomia and orthostatic hypotension. An example of this medication would be an HCTZ. Also, NSAIDs, NSAID, they reduce diuretic effectiveness. Some loop diuretics would be like LASIK. They're mostly used for heart failure fluid retention. Okay, ACE inhibitors, those are prils. They block the conversion of angiotensin 1 to becoming angiotensin 2. The result of that is vasodilation to lower the BP. Side effects of that, orthostatic hypotension, dry cough, altered taste, and angioedema. The cough happens because of the bradykinin, which causes the smooth muscle contraction and inflammation. And that's why they are ARBs, those end in sartan. Those help the coughing. So they block the receptor for the angiotensin 2 instead of its production. And they have fewer side effects, so there's no dry cough. But it still causes a vasodilation to lower the BP. Next, we have the calcium channel blockers. They end in dipene. They are used for hypertension, arrhythmia, and angina. They basically slow the SA node conduction and cause vasodilation, less afterload, and lower BP. They are safe with NSAIDs, but it is better to take Tylenol or acetaminophen. Common side effect, gingival enlargement. That's the big one. Xerostomia, taste changes, and orthostatic hypotension. Beta blockers, they block B1 and B2 receptors. They decrease heart rate and BP. Used for hypertension and anxiety. With non-selective types, do not use epi because they can have a risk of a hypertensive episode. Alpha blockers, they cause peripheral vasodilation. They lower the BP. They are used for hypertension and prostate issues. NSAIDs reduce effectiveness. Side effect of these, orthostatic hypotension. And if you don't know what that means, it means you're going to get dizzy when you stand up and your BP drops when you stand, not rises. So anyways, cardiovascular drugs can be tricky. But once you know the main groups, it's so much easier when you connect them, especially to what you learned in anatomy, like the AC mechanism with the renin and the liver and angiotensin. It's so much easier to connect it all when it makes sense. Anyways, I hope this helps. Have fun studying and I'll see you later. Bye!